So whenever this question is there, pregnancy-induced hypertension and anesthesia, first as you started with rightly, you must first define what is pregnancy-induced hypertension. What are all the classifications? Of course, you have to include that there. Second thing is what is the pathophysiology. Third is what are the clinical presentations. Shukla beautifully described the various systems that are involved and the symptoms the patients will have. Then comes the decision making. This question of decision making is about whether to allow the pregnancy to continue or terminate it, because that is the ultimate treatment for control of the blood pressure in this condition. Then what is the monitoring and management you have to do. Third is the preoperative investigation. What are the investigations we have to carry out? And how do you manage the delivery, whether it is by natural methods or by C-section? What are the complications and their management and allied topics? This will be the overview for this presentation. So hypertensive disorders of pregnancy are one of the most common medical problems which we mentioned, and it has the highest maternal and fetal mortality and morbidity. And it is defined as a new onset hypertension after 20 weeks of gestation. So this is what I just now explained, why we have to wait for 20 weeks, because that is the time the implantation of our placental adherence to the uterine myometrium is complete. And it is classification, as already Shukla mentioned, can be pre-eclampsia or eclampsia, which is onset after 20 weeks, and proteinuria is a must. Earlier, they were including three things as classical features of preeclampsia: hypertension, proteinuria, and edema. But later on, the edema component was removed, and now we have only two things: hypertension and proteinuria, and the onset time is very important. Second is the pregnancy-induced hypertension, which is also called as a gestational hypertension. This also happens after 20 weeks with the increase in blood pressure of more than 140/90, but there is no proteinuria in this case. The third category is patients who had hypertension even before they became pregnant, which is called chronic hypertension, which may continue without becoming a preeclampsia. Patient may continue to have the same chronic hypertension throughout pregnancy also. Whereas the fourth category is where a chronic hypertension in which preeclampsia is superimposed. So the high BP has been there even before pregnancy, but after the pregnancy they start developing proteinuria. Then you call it as chronic hypertension with superimposed preeclampsia. Now, pre-gestational hypertension can be one of the following. Just like a regular hypertension, it can be essential, white coat, or masked hypertension. So these are all the conditions where it can be because of that. The second variety or variant is what is called the HELP syndrome, which he described. This was coined by Weinstein in 1982. So this is supposed to or considered as the most severe form of eclampsia or preeclampsia rather. And there are various theories which he mentioned. So till today there is no clear-cut proved cause. So there are various speculations or theories which are being used to describe why this is happening. But it is basically a two-stage process of pathogenesis. One is abnormal placentation with endothelial dysfunction with a wide spectrum of the disease. So what happens in stage 1? Abnormal placentation. The placenta is not adherent to the myometrium properly, and the vascular remodeling does not take place in the correct way. So both of them result in decreased placental perfusion. What are the causes for that? It can be maternal, which is genetic, behavioral, environmental, or in the stage 2, the maternal syndrome of preeclampsia with endothelial dysfunction. So in stage 1, it starts at the placenta and uterus level, In stage 2, it spreads to the entire body. So it becomes a maternal syndrome of preeclampsia, and endothelial dysfunction occurs all over the body. The maternal syndrome is characterized by decreased perfusion due to vasospasm and activation of coagulation cascade with microthrombi formation and end organ damage. This resulting endothelial dysfunction produces an imbalance between, so whenever the perfusion is affected, new blood vessel formation is always the repair mechanism that nature will try to attempt. So there are pro and anti-angiogenic factors which have an increase in but the anti-angiogenic, that is new vessel formation, is prevented by the anti-angiogenic factors. So what this imbalance is considered to be the cause for the development of preeclampsia, and the factors are vascular endothelial growth factor and placental growth factor, and increased concentration of their antagonists. So the pro-angiogenic factors are growth factors. It may be of vascular endothelial origin or from the placenta itself. But this is countered by the antagonist, that is what is called the placental soluble fragments like tyrosine kinase 1. This is the culprit who is antagonizing the growth of angiogenic factors. So that is how that imbalance causes. Earlier they were saying it was an imbalance between prostacyclin and thromboxane, but that described only the vascular spasm and the coagulation. That did not describe about the new vessel formation to counteract this vasospasm and irregular blood supply to the entire body. So that is the reason why the new concept of the imbalance between pro-angiogenic and anti-angiogenic has come in, and that has been the latest theory which has been accepted. Now coming to this picture will tell you very easily what is this abnormal placentation. You have the normal pregnant vasculature is depicted here, and in preeclampsia what is happening. See, normally the myometrium, which is the one which has to supply the blood through the uterine branches, the cells, and it goes to the decidua and placenta. So this is the placental villi. So this is the communication from the mother to the placental, through which the infant or the fetus has to get its blood supply. So what happens? This maternal arcuate vessels which are there, this interrupted dark lines are the muscle coat in the vessel. So if you have a smooth muscle in the vasculature, they will have the tendency to constrict and relax based on the stimulation or the inhibition. But in normal pregnancy, what happens? Up to 20 weeks of gestation, slowly this muscle coat in this vessel is completely lost, and it becomes just a conduit to allow the blood to flow towards the placenta. So there is no auto regulation because there is a lack of musculature happening here. Whereas in patients who have preeclampsia, this muscle coat is retained, and this spiral, the so-called spiral artery, which is the branch of the uterine artery, their muscle coat is still retained. So you can logically think where this will have more blood flow because there is no constricting mechanism. It's just a conduit and it goes on expanding, so more blood can flow here. Whereas here, because of the muscle coat, this is constricted and less blood flow is only going. So placenta is not receiving adequate blood, so there is an ischemia. This is what is happening in stage 1. So the failure of, so this is what they call as trophoblast invasion. The cells from the placenta, they try to invade and remove this muscle coat. That is what is described as the trophoblastic invasion of the spiral arteries. And if that doesn't happen properly in preeclampsia, the muscle coat is still remain in the vessel, and constriction happens and inadequate blood flow ensues and ischemia ensues. So failure of conversion of small caliber resistant vessel to large caliber capacitance vessel. That is what is happening. So when the muscle coat is there, it acts as a vessel with resistance. When that muscle coat has been removed or by the invasion of trophoblast, it becomes what is called the large caliber capacitance vessel. In stage 2, endothelial dysfunction starts. So imbalance between vasoconstrictor and vasodilator as well as pro versus anti-angiogenic factors occur. So these are all the changes happening in the entire maternal circulation. So what started at the placenta as an abnormal placentation, resulting in ischemia and hypoxemia at the placental level, produces a lot of reactive oxygen species, enters the maternal circulation, and everywhere this imbalance between vascular endothelial growth factor and soluble film fiber factors, all these things happen everywhere in the endothelium, and nitric oxide also is affected. So vascular smooth muscle is affected, oxidative stress is produced. That is how, and calcium influx alteration takes place, superoxide ion. So there's a generalized inflammatory changes that happen throughout the vasculature of the pregnant woman, which results in this particular systemic disorder. So net effects are vasospasm, capillary leak, activation of coagulation. Okay, so these are the changes that happen in the mother circulation also. I hope this description is sufficient for describing how it is happening. So again, the same thing in another form. So 2 stages, preclinical less than 20 weeks, inadequate inflation and of spiral arterioles, and vasculature remodeling does not happen. After 20 weeks, oxidative stress and hypoxic placenta, producing generalized systemic inflammatory response with release of anti-angiogenic factors and inflammatory cytokines, producing maternal syndrome. So early onset preeclampsia occurring before 34 weeks of gestation, that is what we described, and two categories of mild and moderate severe preeclampsia. This thought to be primarily caused by syncytial trophoblast stress leading to poor placentation, whereas late onset preeclampsia occurring after 34 weeks is understood to be secondary to the placenta outgrowing its own circulation. So this is a small difference in the concept of preeclampsia occurring early in the pregnancy and late in the pregnancy. So early onset preeclampsia is more frequently associated with fetal growth restriction, logically, because already there is a placental ischemia, so you don't expect the fetus to grow normally due to longer duration of placental dysfunction. And grading and symptoms is another important thing. You can, that is based on the blood pressure reading. It can be mild, moderate, and severe. So severe is considered when systolic is more than 160 and diastolic is more than 110. Just like your hypertension, essential or secondary hypertension is graded, the same thing is applied here also. And symptoms associated in severe or preeclampsia: constant headache, visual disturbance, upper abdominal pain, nausea and vomiting, sudden swelling of face, feet and hands, brisk deep tendon reflexes. And what are all the systems involved? That is how we classify it. Hematological system, it causes thrombocytopenia, altered coagulation, or a pattern like HELP syndrome. The biochemical impairment can happen in the kidney, altered urea, creatinine, sodium, potassium, and proteinuria, the elevated urine protein creatinine ratio, and liver also is affected, especially in HELP syndrome, low albumin, low glucose in severe cases, elevated liver enzymes, and bilirubin levels are also high, so the patient may be jaundiced. Usual blood tests in preeclampsia are full blood count. CBC is very important with emphasis on platelet. Clotting screen, if required, if platelet is less than 100,000. And request for a blood film if HELP syndrome is suspected. And urea and electrolyte, serum creatinine and serum urate, liver function test, all these things have to be done. And you can do urine dipstick for protein level assessment. So various categories of protein excretion also described. And the urinary protein creatinine ratio forms a random sample with more than 30 milligram per millimole sometimes quantify the proteinuria, and 24-hour urine collection for protein estimation, midstream specimen to exclude urinary infection because they can develop UTI very commonly. Urine output must be accurately monitored and recorded. This is very important because, as I said earlier, one of the reasons for mortality and morbidity is urinary renal failure. And use of ultrasound in eclampsia. What are all the uses? You can do especially severe cases with lot of edema. USG is very useful in airway evaluation. You can measure the gastric volume measurement before you take them up for any surgery to assess the risk of aspiration. Then you can sometimes have difficulty in getting a vascular access in this patient because the edema will prevent you getting an IV access in the periphery. So USG can be used for a central line. And lung fluid assessment also will be helpful to assess whether the patient likely to go in for pulmonary edema. And optic nerve sheath diameter measurement is useful to assess the severity of cerebral edema in these patients because of the severe hypertension and hyperproteinemia. And neuraxial blockade, if the back is very edematous, when you want to do a neuraxial blockade, palpation of the bony points or landmarks will be very difficult. In that situation also USG will be useful. And then what is ROSE scan? It's called rapid obstetric screening echocardiography. It's done nowadays. This is performed using transthoracic echocardiography to assess the fluid status. So this is one of the recent things. So you can sometimes examiners may ask you about this. So rapid obstetric screening echocardiography, otherwise called the ROSE scan. The factors associated with the development of preeclampsia are, it can be pregnancy associated factors. Usually it can occur in first pregnancy, sometimes in multiparous women also. And donor insemination, when you do an artificial fertility procedure, you do a donor insemination, that can also be the cause for this. Molar pregnancy or chromosomal abnormalities. Then maternal induced factors are the mother is very old or very young, family history of preeclampsia, and if the booking diastolic blood pressure of 80 or more is there, they are likely to uh, go in for this. And any associated comorbidities like diabetes, obesity, chronic hypertension, and the existing renal disease, all these things also can be causative. And antiphospholipid antibodies or factor V Leiden and the SLE patients who suffer from such autoimmune problems, they are also likely to develop. And paternal factors, first time father. What are all the life-threatening complications? Hypertensive crisis, pulmonary edema, eclampsia. These are the three life-threatening complications of eclampsia. And Tibi's criteria is used to distinguish between true or complete health syndrome, which is abnormal peripheral blood smear, where you will get reticulocyte count will be more. Bilirubin is more than 1 to 2 milligram. LDH is more than 600 international units. AST is more than 70 international units, and platelet count less than 100,000. These are all the factors to classify a patient as a true or complete health syndrome, which is called the Tibi's criteria. The complications, again going back to that, in maternal you can get a cardiovascular system, generalized vasoconstriction and decreased circulating volume because the vascular tree is consisted. Most of the hypertensives will have this problem. There will be generalized vasoconstriction and circulating blood volume will be low. And left ventricular failure caused by increased vascular permeability and edema. In the nervous system, headache, visual abnormalities, vomiting, confusion, hyperreflexia, or they can go for hemorrhage due to severe systolic hypertension, convulsions due to cerebral irritability, and the respiratory system, there can be generalized edema with enhanced upper airway edema, non-cardiogenic pulmonary edema due to capillary leak. That is what I described earlier. Continuing with the complications, renal complications, glomerular capillary endotheliosis and microthrombi, reduced glomerular filtration, reduced urea clearance, and increased serum uric acid. They are the markers for the, so if you measure the serum uric acid and if it is more than 7 milligrams, it is an indication that the kidneys are getting affected. And proteinuria and hypoproteinemia, oliguria and acute renal failure are very common. In the liver, they can have abnormal LFT, subcapsular hemorrhage, and that is the cause of the right upper abdominal pain. Sinusoid thrombosis can happen. And in the hematology, altered coagulation, increased turnover of fibrinogen, fibrin, and platelets, thrombocytopenia and impaired platelet function, disseminated intravascular coagulation. This is one of the most dangerous complications. If it sets in, mortality is very, very high. HELP syndrome, again, is another hematological description. What are the complications that can happen in the fetus? Decreased placental perfusion leading to ischemia and infarction. And the baby is usually small for the dates of pregnancy. And suddenly, sometimes placental abruption may happen. Preterm labor is also very common, which is more common in the early onset preeclampsia. Controversial areas in clinical management. If preeclampsia develops at early gestation, when and how you should deliver? When is invasive monitoring needed? This is the second controversy. What are the benefits and risks of various antihypertensives? How should we manage an eclamptic seizure? Why magnesium is preferred over other anti-seizure medications? How should we manage fluids? Platelet count, what is the safe value for neuraxial block? Is spinal safe in severe preeclampsia? Should phenylephrine replace ephedrine to treat hypotension? So these are all the areas which we have to find the answer. Coming to the management strategy, only cure for preeclampsia is delivery of the fetus and placenta, that you should remember. So always there is a dilemma which comes important: maternal safety versus fetal prematurity. Which one we should avoid or which should be prevented? So gestational hypertension or mild preeclampsia, patient can be managed at home with frequent monitoring and fetal surveillance. Severe preeclampsia cases need admission in the hospital. Favorable cervix. This is what the physician will tell you. Favorable cervix with adequate fetal maturity after 36 weeks can undergo induction with proper pain relief. So if the cervix is showing signs of dilatation, that is what is called the favorable cervix. And if the baby is more than 36 weeks, which means the maturity is complete, and even if it is born, it will not suffer from lack of surfactant and respiratory distress syndrome. So we can allow this lady to go for a normal vaginal delivery, but the caveat is you must provide adequate pain relief because the labor pain can trigger hypertension and it can lead to complications. So if the BP is well controlled with all the antihypertensive medications and the cervix is showing good dilatational properties and the baby is 36 weeks or more, definitely normal vaginal delivery can be attempted. Whereas if it is unfavorable cervix, so it is not dilating, with adequate fetal maturity, it can be delivered by elective lower uterine cesarean section. So you can plan for an elective seizure instead of allowing the labor to get started and allowing the mother to suffer from pain. But if it is less than 34 weeks with severe preeclampsia, you must just delay the delivery for 48 hours so that you can administer dexamethasone or betamethasone and allow or get the maximum lung maturity and then deliver the baby. So that is the only criteria. And magnesium sulfate infusion and IV antihypertensives, if the BP is more than 170, 110, should be routinely started. And HELP syndrome, treat with large doses of dexamethasone, which is 10 milligram BD, should be started even if you suspect HELP syndrome in the mother. Most important dilemma in treating hypertensive crisis is the maternal complication prevention versus fetal safety compromise. Again, the same dilemma will happen. So, if the maternal BP is high, there are chances of pulmonary edema or cerebral hemorrhage. These are the two acute complications which can have a mortality. So, high systolic BP causes cerebral bleed and stroke. So, invasive monitoring is rarely needed since most are young patients with fewer chronic illnesses. But if it's an elderly mother with already existing hypertension, then definitely invasive monitoring is indicated. But arterial line is useful in majority of the patients because a consistent BP, if it is more than 160, 110, who are on IV vasodilators, arterial line will give the correct measurement of BP rather than non-invasive blood pressure. And those who have coagulopathy and need frequent samplings to determine the coagulation profile as well as the blood gas analysis, they will definitely benefit from an arterial line. And those who are obese or severely edematous, patients who have generalized anasarca, they will also require an arterial line. And if there is pulmonary edema or frequent ABG is needed, again, they will require arterial line. How do you manage the hypertensive crisis? CVP or a PA catheter are not usually used because of the risk of bleeding, need for trained nurses to manage that, but they are indicated in cardiac failure, pulmonary edema with a large alveolar to arterial gradient, oliguria despite fluid resuscitation. So what are the drugs you use in the management of hypertension in pregnancy? Earlier we were using methyl dopa, oral route 250 milligram, up to 3 grams per day in divided doses. It acts as a false neurotransmitter to norepinephrine. So norepinephrine causes vascular constriction, and that is a major, but this is mimicking its structure and blocks the effect of norepinephrine. Side effects are postural hypertension, sedation, depression, bradycardia, headache, and hemolytic anemia. So some examiners may still be very fondly asking about this drug, which was the very commonly used drug in the ester years. And contraindications were liver disease, increased risk of postnatal depression. Then the next drug which is commonly used is labetalol, which is given orally as well as it is given parenterally also. IV can be given. Oral is 200 to 1600 milligram, IV 50 milligram bolus followed by titrated infusion. It is a combined alpha and beta blocker. So it blocks both the alpha receptors and beta. But the ratio of alpha to beta blocking effects depend on the route of administration. So for oral, it is 1:3, more lesser beta blocking effect. Whereas in parenteral, it is more beta blocking effect, that is reduction in the heart rate and blood pressure will be more pronounced in beta IV administration. So 1:7. Side effects are bradycardia, fatigue, bronchospasm, GI disturbances. It is contraindicated in asthmatic patients or patients with severe restrictive heart diseases like aortic stenosis, pheochromocytoma, and all those kinds. Other drugs commonly used nowadays, many gynecologists prescribe nifedipine routinely, 20 to 90 milligram. Earlier we were giving sublingual and intranasal. Now both the routes are strictly contraindicated. So never say those routes in examination. Calcium channel antagonist blocks entry of the calcium. They act, their mechanism of action, I think all of you know. Side effects, headache, dizziness, tachycardia, etc. Contraindications, aortic stenosis and liver disease. The next drug is hydralazine, which is available only as a parenteral preparation, IV, only 5 milligram slowly, followed by 5 milligram per hour as an infusion. This is the main drug used for control of hypertensive crisis. It acts by activation of guanylate cyclase and increase in intracellular cyclic GMP, leading to decrease in intracellular calcium and relaxing the vascular smooth muscle to cause vasodilatation. Side effects are fluid retention, flushing, palpitation, headache, dizziness, tachycardia, SLE-like syndrome, and peripheral neuropathy. Contraindications, severe tachycardia, you should not use. Then sometimes you can use alpha blockers like prazosin, which all have these effects. And beta blockers, pure beta blockers are rarely used but can be causing these problems. Diuretics, what is the role of diuretics? They act on the various sites of nephron, but the side effect is neonatal thrombocytopenia. So that is why even though there is edema, we don't use diuretics commonly unless there is a frank pulmonary edema in these patients. And magnesium sulfate, you must know everything about it. Examiners are very fond of asking all the details about how the mode of action. It is an antagonist to calcium channels, reducing systemic and cerebral vasospasm. And NMDA receptor antagonism is also there, which is the main reason for anticonvulsant action. Increased production of endothelial prostacyclin, which restores thromboxane prostacyclin imbalance. And side effects are therapeutic range 2 to 4 millimoles, loss of deep tendon reflexes, then vision will get blurred at 5 millimoles, respiratory depression will happen at 7 millimoles, and cardiorespiratory arrest will happen at more than 10 millimoles. That is why it has to be given as a slow bolus IV, not rapidly. Contraindications for its use in case of cardiac arrest: stop infusion, start CPR, give 10 ml of 10% calcium gluconate IV, send magnesium level to lab urgently, care when using the nifedipine. So if the patient is already on calcium channel blockers like nifedipine, they may act synergistically. So be careful when you use this in patients who are receiving nifedipine for a long time. So magnesium also crosses the placenta to cause neonatal hypotonia and respiratory depression. So how do you do the prevention and control of seizures? IV Maxel 4 milligram bolus over 10 minutes, followed by 1 to 2 grams per hour until 24 hours post delivery. The maintenance dose is stopped or decreased to 0.5 grams per hour if the patient is oligouric or if the serum magnesium levels are high as measured in the lab. In the event of recurrent seizures, a further bolus of 2 to 4 grams per minute is given. If further seizures occur despite above, inform the intensive care unit and additional seizure treatment may be required, necessitating airway support and ventilation. So 44% of patients who throw a fit, eclamptic patients, after delivery, postnatal vigilance is also very important, although this may resolve spontaneously. So what are these methods? What are the steps to control seizures? Administer high flow oxygen, turn patient to full left or right lateral decubitus, reduce the bite block, suction and clear the secretions from the oropharynx. Small doses of thio or propofol can be given. Additional 2 gram magnesium. CT MRI if seizure is recurrent or rule out cerebral hemorrhage. Consider delivery by either induced or LSCS. And what is the fluid management? Two changes in preeclampsia. They have a contracted vascular tree causing a contracted blood volume, and sudden vasodilatation if a vasodilator like hydralazine are administered. And they have leaky capillaries causing pulmonary edema compounded by reduced plasma albumin due to dilution or proteinuria. So safer to err on the side of less fluid intake in these patients. So maintenance fluid intake, including all IV infusions, should not exceed 1 ml per kg per hour. And urine output should be monitored to have an output of 0.5 ml per kg per hour. And if it is 2 ml, supposing it is not draining hourly, you should have at least 2 ml per kg over 4 hours period. So these two are the methods. So don't expect a prompt hourly output. You can accumulate it over a period of 4 hours and see whether you get at the rate of 2 ml per kg over 4 hours. This is also accepted minimum. Co-loading is preferred to preloading. Coming to delivery management, time and mode of delivery is dependent on the severity of the condition and gestation of the fetus. The decision to deliver depends largely on maternal rather than fetal well-being, as delivery improves the maternal disease. So what are the anesthetic considerations? Choice of anesthetic technique. Regional technique is preferred in most of the cases. Hemodynamic stability following spinal anesthetic was comparable to epidural blockade. So it is not always mandatory that you should only give an epidural. Even a single shot spinal has been proved to be quite safe, but there are some adjustments or modifications you have to do. Subarachnoid anesthesia in women without an epidural in situ or spinal or combined spinal epidural is preferred. These are all the 3 neuraxial blockade techniques that you can use. Coming to epidural analgesia, advantages are helps to control the BP, improves placental blood flow, abolishes labor pain, and it can be extended to provide operative anesthesia as well as postoperative anesthesia. The disadvantages, not suitable in patients with low platelets, more chances for hematoma formation. Coming to general anesthesia, the indications are whenever there is a contraindication for regional like coagulopathy or low platelets, or a patient who had a post-ictal, that is after the seizure, if their level of consciousness is obtended, or patient who is throwing repeated fits, those patients are not fit for regional. But if there is only one episode of epilepsy or seizure and patient is fully conscious and alert and you want to immediately do an emergency seizure, you can definitely give a subarachnoid block. There is no contraindication at all. Please remember that. Only if they develop recurrent seizures, then avoid spinal. Or if their sensorium is altered, avoid spinal. Otherwise, after a single epileptic attack, there is no contraindication if the patient is fully alert and active. Presence of pulmonary edema is also another contraindication for regional, so you have to go for GA, especially if they are associated with hypoxia, and patient refusal as usual for any stage. And the pressure response to laryngoscopy can lead to dangerously high surge in blood pressure that may lead to intracranial hemorrhage. As I said again, the most important cause of maternal mortality or prolonged unconsciousness in a pregnancy with preeclampsia is intracranial hemorrhage. So measures to attenuate that response, again magnesium and labetalol and potent parenteral opioids like alfentanil can be given. I think most of you would have noticed why we are not using esmolol, why we are recommending only labetalol. I think one of you should answer that question. Antacid and antiemetic premedication is a must as always for any labor patient. Antihypertensive and anticonvulsive drugs should be continued. Intubation may be more difficult due to edema, so we must keep smaller size tubes ready and a fiscal cart, airway cart. Decreased pulmonary compliance may impair ventilation. So if the woman has received magnesium sulfate, muscle relaxation must be carefully monitored using a nerve stimulator. And routine use of ergometrin or symptometrin is avoided. If many physicians nowadays they don't use these drugs, but if the institutional protocol is to follow give ergometrin, that should be avoided in these patients. And syntocinon is advised. Non-steroidal anti-inflammatory drugs should not be routinely used because of the effect on the renal and placental function. Paracetamol may need to be withheld if there is evidence of liver dysfunction. Now, what are the allied topics that examiners may ask you is physiological changes during pregnancy, anemia complicating pregnancy, anesthetic management of elective emergency LSES, management of antepartum and postpartum hemorrhage, labor analgesia, neonatal resuscitation, supraplacental circulation. So all these topics can be diverted from the main topic because examiners don't like to ask the same question repeatedly to everybody. So they can jump to any of these allied topics and proceed in that and ask you also. So in the Viva, you have to be aware of all these other topics also.